Can you hear me?
Yes,
Yes, we can hear you.
Woo! Good. I was having trouble in audio the other week. I had like 3 Zoom meetings that day, and it was not fun. A folder here. Just getting into a folder.
Oh, Dave, I got an email from you today. I didn't even notice.
That's okay. I didn't have much
Just
important
thought,
to
man,
say.
what a good I am.
Mm-hmm. No worry. I was just gonna just double check today because I figured, the article we kind of skimmed over last time on trigeminal facilitation. We're gonna go
Yeah.
deeper into that. If you feel like we're good with that, then we can move on to some of the other curriculum or things from the course that may be valuable to them.
Yeah, I mean, I always feel like there's always more things we can go over with the trigeminal stuff, but
Yeah.
yeah, I can go either way, I guess.
Yeah, maybe inclined to go back to the case. We haven't done a lot of cases with this group, so it might be good to go in detail. And I think what we do is we break that. My plan is to break that case out and say, okay, what are the other differentials involved in this? Because we narrow in on this in the article, but in the back of our minds, we're going over all the other differentials and ruling them in and out. But that's
Yeah.
happening in the peripheral vision, not so much the focal vision.
Yeah. No, that's not a bad idea. I like it.
I think the more casework we do, the better, in my personal opinion. But I don't run the class,
Mm-hmm. No, that was that Abby.
Of course it was.
Okay, good. Yeah, your opinion matters less. But if anyone else would like to put something in there. Oh, Abby, you know that's not true, right?
You don't hurt my feelings anymore, Dave. It's been
Good,
too long.
good.
The
It should be
correct
hard
answer is you no longer have feelings.
Bam.
Oh, man, tough crowd today.
Oh,
It's Thursday.
I'll blow this up so an old guy like me can read it. All right, can you see my screen in the article?
Yep. I can anyway.
Okay. Okay, this case was a nice one written up. I liked it. It was clean in how it was written up. We read it as like, oh, okay, I can almost tell who wrote the article just because they were trained, a similar background as, the model where Jim came from and Earl Petman and, Diane Lee and those individuals came down. So as I read it, it kind of read to us. We talked about whiplash earlier, so it's kind of nice to tie in. Okay, we have whiplash, motion, associated disorder, from the head impact. We discussed, the trauma to the upper cervical spine, the lower cervical spine, how it goes, and pathology that occurs there. We also got into a bit in the pathology that, multiple things can happen pathologically from, let's talk about fractures, rim lesions, lower cervical spine, annular tears, herniations, ligamentous ruptures, dislocations, muscle strain, cord transection, nerve stress, vertebral artery dissection. It's a few. The common one they don't mention in there is one of the most common one is certainly traumatic arthritis or inflammation of the facet capsule. That's one of the more common ones that also occur in these automobile accidents. And that kind of comes back into this case and where you're seeing somebody years later with this. But in our minds, you get somebody acute, you can have any one of these things. I think Eric and I talked about as we look at this case, is to think about is we think about like vertebral artery dissection, this thing. And I think with Eric and I is, we've said is like, I don't generally look to manipulate these people in the first 6 weeks. And
Definitely not.
And it's because you can have these intimal tears, these things going on that you just don't know. It's subclinical. You're not going to get it. You're not going to get it with your vertebral artery testing and your progressive testing. So anything that I can do, if I find something that I can release by understanding the biomechanics of the joint, gliding it through it, doing a more gentle technique by applying the biomechanics we've learned is what I would use in the early going with this individual if I felt like I needed to address something that was stuck. In this case, maybe it was a T2, T3, or if it's occiput C1. Eric, what do you do manually in these acute cases early on?
So within that first 6 weeks?
Yes.
I mean, the easy answer is kind of what you were just talking about, at least looking at the symptomology that the patients had. But the problem is that when we're dealing with, what you'd consider an occult neurovascular injury, right? So if they have intimal tearing that results in some kind of clotting method right within the vertebral artery, they may not have any symptoms at all, right? But the risk then becomes, if I perform some sort of high velocity technique to the neck, could I dislodge that thing, right? So that's kind of where you get that. We don't really want to deal with these things within that first 6 weeks because we just don't know. Even if our VBI testing is coming up negative, it may only be negative because this particular clot hasn't moved to a position where it's going to be problematic for us. So I usually try and stay in a situation where we're doing some sort of oscillatory mobilization, trying to stay, relatively as gentle as you can get. And in a lot of times I won't, if I'm really suspicious or if there was a significant, kind of violence to the patient's injury, to the incident, so motor vehicle accident, et cetera. Basically, you can kind of follow the Canadian C-spine rules with stuff like that and say, okay, if they meet up with any of these sort of things, I'm going to want to give it that 6 weeks before I really do too much to the neck in general, because at the very least, you want to get some of that tissue, some of that vascular tissue to heal, but also to eliminate any type of inflammatory processes that might be in the realm as well. So most of the stuff that I'm going to do there from a manual therapy standpoint is we're going to try and do, kind of very graded, very slow to progress type of mobilization things here. And most of it's going to be more cueing just with where my hands are, right? So I'll position their head and I'll ask them to try and engage some of the musculature in some of those positions. So we're almost doing more neuromuscular components in those early stages rather than trying to do anything that's a high velocity or, into some of these barriers. Just because, from my perspective, it's not worth the risk to wait, versus waiting that full 6 weeks. And again, the 6 weeks is kind of it's a relative number. Research has shown that these things will dissipate within that 6 weeks, but you have to take into consideration the entirety of the patient's constitutional health, right? We've talked about this before. If somebody has other vascular issues, high blood pressure, if they have diabetes, if they've had prior, vascular procedures done like cardiac surgeries or stents or varicose vein procedures, any of these sort of things that might affect the ability of the vascular system to heal. You have to start taking those into consideration and then spreading out that time as you're going through that process in your head. But no, I think for the most part, it's, be as gentle as you can, try and avoid high velocity end range techniques, and that, especially in that early phase. And then you kind of work your way up from there, depending on how the patients respond.
Yeah, what Eric addressed a lot of what's here on the right-hand column as far as, what are we doing in treatments? We are looking for active cervical range of motion will be lost, looking at restoring active cervical range of motion. altered muscle recruitment patterns. It's common. It can be in many ways, but the early gentle tactile cueing is the way of working on some of that muscle recruitment patterns. That overactivation of upper trapezius when it should be down ramping with rotation. Am I getting the deep system, semispinalis, cervicis versus, capitis in many cases? Postural control, joint kinesthesia, we're all familiar with the joint position error test. That can be aberrant and certainly in these individuals as well. So these things are all important. Balance in these individuals too is often overlooked, and looking at the balance and postural sway, as well as eye control is a possible complication. Do they have that? So kind of like what you saw us do a little bit with Michelle, and just understanding, what is the integration of her eyes to suboccipital system, eye control to vestibular system. And with her, we saw eye control and altered muscle recruitment patterns in the neck. So looking at those things in that early 6 weeks phase would be kind of important for me, and where I'd be spending a fair amount of my time just getting the down ramp and see where the dust settles.
Yeah.
Psychological stress, anxiety, pain catastrophizing, those things, multiple factors with that. The number one you often see coming back with this is, joint, problems at work, or is it going to be, basically other financial gain? But there's other things, and those people, when you have these things at baseline, it's only going to accentuate it. The hidden piece in this, if it's a chronic post-concussive, is the role of how the vestibular ocular integration system, upper cervical and limbic system influence. Fred would probably be the one to talk to that a bit, but the concussion and how it impacts those things. And many times it can't just be something in the way they process it. It's the way the vestibular input has influence over the limbic system in chronic post-concussive cases. And it can drive a lot of this, including the fog. But we'll be on this article, but hopefully we'll get into it in the future discussions and cases. They're talking about manual therapy and high velocity thrust. And it's good is that this is what we're learning on this course. Your goal is to come out of here, and we want to cover the areas, but where you should be now is realizing you have all the specialty you need to treat 90% of what's going to come your way. And you have high velocity thrust techniques for basically everything through the spine except for probably C1, C2. Again, keep it in mind that joint facet irritation is a very common one. And this individual in particular is coming in much, is it 19 years after the initial MVA. And again, one of the other things we'll talk about here is there's the mechanical effect of the manipulation, but again, we also talked about too the pain relieving effects of high velocity manipulation. Neuroplasticity, altered input into nociceptive circuits, and pain modulation. Think of that person who likes to chronically manipulate their own neck and make it feel better. They're really looking for that neurophysiological release more so than the mechanical release.
I find that funny because as I'm sitting here trying to do it to my own neck while we're talking about it.
Yeah. You just kind of crave it after a while.
Yeah. Don't get old, guys. Don't get old like I did.
And again, and these things will all tie into, as we talked about, the trigeminal influence, and from C1, C2, and C3 is where we're going here. All right, so let's get to the case report. 65-year-old woman presents with outpatient physical therapy, evaluation, treatment of neck pain, dizziness, and headache. Now, if we're here, I don't have my list of people in front of me, but Patrick, how would you discriminate dizziness in this individual to strengthen your idea that this would be mechanical and from the neck versus something else?
During subjective, I would ask, is dizziness ever present without her neck pain? Versus is neck pain always present like when she gets dizzy? That would kind of cue me in to see if they're truly related or not.
Yeah. Yeah, Kevin, what else would help you differentiate it? That was good, Kevin, or Patrick. What's another way with your questioning and your subjective could you differentiate the dizziness from being from another origin? If Kevin's not there, I have to switch over to my list. It's hard to think and do this. Who else? Give me somebody else. Give me one. Teresa, I can remember your name. What other differentiation one? Kevin gave us one of, is the pain coupled with the neck pain, or is the dizziness coupled with neck pain or not coupled? And to this area, Kevin was looking, or Patrick was looking to couple it. Where it's always coupled, it's more likely to be coming from the neck. Teresa, how would you differentiate this from potentially vertiginous dizziness?
You guys are all getting busted for not paying attention.
Mm-hmm.
Although I don't see Teresa's name on here.
Maybe I had to put my names because it's showing my screen and not my people. Chan, you're up, buddy. I'm back to my screen. Let me share again.
I would think that you would almost orthostatic in the sense when you get up, or you dizzy then, or is that kind of what you're going at? Movements.
You could be doing that because you're looking there, is it orthostatic hypertension or orthostatic dizziness versus that? So that would be one thing you could consider, is that, okay, is this orthostatic dizziness she's getting? Does it change with position? And what would that dizziness, how would that dizziness be different from, say, vertiginous dizziness?
With the orthostatic, you would think that it would stabilize after they're up and moving or up in that position for a minute, versus more to me of a head movement causing the dizziness.
It'd be that, but even like the vertiginous dizziness, once you're still for a little bit or change positions, it tends to settle down a bit. But you're right. What about the quality of dizziness? How does the vertiginous dizziness feel different than orthostatic driven dizziness?
Yes, orthostatic is almost a lightheaded or a visual disturbance, versus to vertiginous, you almost feel woozy or head spinning.
Yeah, it's the rotary component, the spinning.
Yeah.
I feel like I'm spinning, or the room is spinning. Would help differentiate those two. That's what you're looking at too. Even if it's a vestibular patient, you're gonna, again, BPVV, you'd be looking at that. It's one other one. Who else has one? I'm really looking for one particular answer here. And Kristen has it. Kristen, with dizziness, we want to differentiate, let's say, vertiginous dizziness. In this case, how would you differentiate vertiginous dizziness from what you think is possibly trigeminal facilitation?
That's a great question, Dave. Could you ask if it sure. Could you ask if you feel, I guess I'm kind of going off what Chan said, but like the spinning versus like swaying, I don't know. Can you say the question one more time?
It's kind of along the lines we're looking for. Like, okay, is this a type 1 dizziness, which is I have this rotary component to it. I feel like things are spinning, versus a disequilibrium, or a sense of motion, which you
ask how long it lasts?
How long it lasts will tell it. So I'm looking for this person. If it's non-vertiginous dizziness, it may be consistent. It may increase with neck motion, is what we're looking for. But what you don't have is type 1 dizziness. It's usually not a rotary or spinning dizziness when it's going to be from a trigeminal influence or upper cervical spine for that nature. So that makes sense. So we think of types of, go ahead.
Is it more of a type 2 dizziness then?
Yeah. Yeah.
And that's like the more like faint feeling, nausea.
It can be any number of things.
Yeah.
Type 2 can be lightheadedness, giddiness, kind of a fainting type of sensation. There's a bunch of different quote unquote descriptors for it. The difference is the rotary component for vertigo. Vertigo makes you feel like either you or the room around you is spinning. Okay, and there's a technical difference between the two. One is subjective, where it feels like it's yourself that's spinning, and the objective is where it feels like the room around you is spinning. There are linear versions of this, oscillopsia, where they go forward and back, almost like you're, kind of rocking back and forth, or the floor is moving underneath you, but it's more linear. those I believe, if I'm remembering right, that's significantly more rare and more likely to be some sort of nefarious type of pathology. But that's an easy question to ask. Like, okay, does the room feel like it's spinning, or do you just feel lightheaded?
Yeah, it's usually pretty straightforward once you break it down that way, unless they're just an intentionally vague individual, and we all have a parent that way. Again, you see here when her motor vehicle began, she experienced getting pain, dizziness, headaches, which continued to affect her functional tasks over the following 19 years. That's the part that stands out to me, the length of time in this one. So I haven't quite sorted that, why she had had this for so long per se, or why it was never treated. She previously, previous CT imaging ruled out fracture, severe pathology. Years after the MVA, she had been seen in emergency department, by an ophthalmologist, general practitioner, multiple physical therapists. Stopped working due to her symptoms and became depressed. Ultimately, 10 months before her current physical therapy evaluation, she began feeling tingling on the left side of her face, cheek, and jawline. Tingling prompted a return to medical care, and she was cleared by cardiac pathology but remained without a diagnosis. She referred to physical therapy with chief complaint of dizziness lasting 10 seconds with lying down from seated position. And that's kind of where you would then want to differentiate the dizziness.
That's a good question, real quick.
Oh no, it's
In
just
terms of like
Go ahead.
if it would be like trigeminal, since we're talking about like the jaw pain, is that what I'm just clarifying what we were talking about earlier? Is that more type 2 dizziness? And if it was more mechanical, it would be type 1 dizziness, or is that incorrect?
It's probably the other way around. Like with this one, where she had dizziness that's lasting 10 seconds, it's got a temporal component to it, which can be, vestibular as an origin, lying down or seated. So that's where you would need to rule that out, the conversation we had earlier. We'd want to have those subjective questions to say, okay, I want to sort out what type of dizziness she has at that point.
And this will be something, there's a specific test for this. It's called the body tilt test. So if you're looking at it and you're wondering, well, is this a vestibular issue? You want to stir the otoliths within the otolith. Is that the one I'm looking at? You want to stir the fluid within the vestibular mechanism. Since I'm not remembering the name right off the, not spitting it out quickly enough. In order to stimulate a vestibular problem, right? So this is the one where you can kind of fixate the patient's neck or hold their head in place, and you kind of do this to them, and you shake them around to try and stir that vestibular apparatus. And if that reproduces the dizziness while you're holding the neck in place, it's obviously not coming from the cervical spine at that point. It's more likely to be coming from the vestibular apparatus. And that would need some sort of dedicated, vestibular PT, or it would need to be diagnosed some other way. Because it's not a mechanical issue at that point, because the neck has not moved, right? So particularly after 19 years, that would be a real rugged way to have to deal with that for 19 years if you had that sort of vestibular issue. Because what's the most likely reason for her having a vestibular issue post MVA? It's probably a labyrinthine concussion, right? So dislodging something and actually, having this post-concussive issue within the labyrinth, and that would be a really tough thing to deal with for 19 years. I mean, the problem with that is that the symptomology as far as the dizziness goes would be less likely to be associated with the neck pain, less likely to be associated with the headaches, right? Because if the neck doesn't move and you're reproducing the dizziness, then the neck pain and the dizziness they're dissociated. They're not related to each other at that point when she walks in the clinic, right? So maybe she had some type 1 dizziness, or sorry, type 2 type of dizziness initially when she first had the injury, but it's kind of progressed to this where maybe it is more of a type 1. But if it's coming from the vestibular apparatus, then the treatment parameters change pretty quickly. We have to be able to explain why the vestibular system is dysfunctional, especially in somebody that's been dealing with this stuff for 19 years.
So Eric, I'm just curious, what's the difference between that body tilt test and like a Dix-Hall pike? Like what, because I mean, if I'm looking at this patient, vertiginous dizziness lasting 10 seconds, in like something that seems to be positionally related, I would
Mhm.
probably, I would think that first without knowing anything else. I'm just curious kind of what the difference between the two would be.
Well, the Dix Hull pike, you have to position the neck in a certain way, right? In order to bias it to the particular canal that's involved. And there's more than one version of these tests, right, that are associated with um, these sort of dizziness complications. So you have to be able to look at it and say like, oh yeah, it bothers me when I go from sitting to laying down. But the thing is it's like, are you going from sitting to laying down, going straight backwards, or are you going straight to the sides? The point is just it's not much different as long as the neck remains in a stable position. But if you have to turn the head in order to get that sort of thing, or you have to extend the head over a pillow or over the end of a table, or tilt the end of your table down so that it provides that extension moment that goes with that, you can't rule out the neck as a potential component of it.
Gotcha. Makes sense. Thank you.
Hmm?
Yeah, in that case, too, Dick's Hull pike, you'd be extending into C2, C3 on the side.
Yeah.
Again, then it would come down to your type of dizziness. They're getting dizzy, but reproduced it. Is it true vertiginous dizziness? You wouldn't have a nystagmus with cervigenic dizziness. I wouldn't expect. At least I've not read it.
No, I would hope not.
But again, here we have intermittent sharp pain. Top left of her cervical spine, headaches that began, posterior aspect of her head, traveling down her eye, stiffness with loss of neck motion. So that type of headache and that progression pattern, not dissimilar to probably any of us. We've all seen it. It's pretty common. Stiffness, loss of neck motion, common. She's 65 years old. I would expect that she's going to have a significant loss of neck motion no matter what. She's probably going to be fairly restricted through her oncovertebral joint glides, her lateral translations, certainly some facet joints. I expect mid-cervical stiffness in her. But is it that I have this stiffness but I have a joint glide, so she's guarding and it's the restriction? Or is it actually the arthrosis of the oncovertebral joints? So that's just something that a 65-year-old I would expect versus if this was a 35-year-old patient. And left-sided facial tingling, which kind of gets us all a little bit nervous when we hear it first, doesn't it? And she feels like she's looking through a dirty window. So Eric kind of described this one almost to a T in the last session. Felt better in a dark, quiet room. There's just a lot less stimulus coming into the system.
Yeah, the person writing this almost wrote this directly off of Earl Petman's description of trigeminal symptoms.
Okay, and decreased church participation. I'll let that one go. Again, finding extremities, range of motion, myotomal testing, light touch, deep tendon reflex, fairly normal things. The upper cervical ligamentous testing scan was performed to rule out serious pathology, assessing this patient's response. Negative results, transverse ligament, no pain distraction, negative sharp pursure, shear test. Petman, Hotens, they call pikes are negative. Yeah, on this one, I'd be curious. This is that one where maybe you come up with an alar ligament that is torn. Would be one thing. So I would look at upper cervical on her, but I wouldn't be expecting like a transverse ligament tear in this individual. But I would be open to the idea that, hey, some of these odd symptoms, if you have an alar ligament tear, if it laxates on the side, it's going to stimulate a lot of these similar feelings. So I would be looking for that. And though they don't report it in this case, it is something that would be kind of in the back of my mind. I don't know, Eric, have you ever seen alar ligament tears and strains over the years?
Yeah, I've seen a few.
I don't see them all the time, but I've seen them enough every couple of years. And again, last class I mentioned had one, and everyone went and tested it. And then I spent an hour after the class kind of putting her back together because she had this sympathetic, swell. Here we have hyperalgesia, tingling, left cheek, light touch, to facial, trigeminal, sensation tests, motor tests were normal, combination cervical, extension, and left cervical side bending in the upper cervical spine reproduced her chief complaint of sharp pain in the upper left craniovertebral area of the cervical spine. So we have extension and left cervical side bending. So
Hey, it's
pick
me.
on the list. Woo, who's on the list? Stephanie. What does that tell you? If I have pain going back into extension and left side bending, which joint do you think I'm getting with that?
I would go for facet joints.
Woo, good one. Pick a facet joint. Which one? Mind you, we're getting headaches.
Let's do C3, C4.
C3, C4.
Ooh,
You
so
had to
close.
do that with,
Sorry.
with 2, 3 written right below you in the paragraph.
Oh shoot, C2, C3. Sorry, I changed my answer.
On the screen.
It's okay. 3, 4, possible, but you're more likely it's 3 and above is really where your influences are, especially with the trigeminal symptoms. Now, you could have something below it and it's a driver of what's going on above it. That's a possibility. But more likely, you're probably looking at 3 and above as soon as you start getting some of these craniovertebral symptoms or these, trigeminal symptoms. So here we go. PPIVM testing performed, entire cervical spine with patient sitting on plinth. There's visible range of motion restriction reported and pain, extension, and lateral flexion at the left C2, C3. PAVM test C2, C3 was hypomobility, noted with extension. Palpation of mid-cervical multifidus indicated atrophy. And we've chatted about this before, is that you get pain in the facet joint or capsule or even in the disc, for instance, you're going to get inhibition of multifidi. Initially, it is acute and it's inhibition. After a while, it becomes atrophy. When it's in there chronically, it changes fiber types, it becomes fibrotic tissue, get fatty infiltrates, and it's permanently changed. So you lose the ability then to even rehab that segment once it is chronic. So that's what they're indicating that they probably found here, which is expected if it's been 9. So it's been that long.
Yeah, 19 years.
Mm-hmm.
See, this part right here is the part when I read this that makes me suspicious that this isn't a real case.
Yeah, it's pretty clean, isn't it?
This was put together well, because when you think about it, you have to start thinking like, okay, if I have a hypomobility at C2-3, why is it painful? It's not moving enough for it to be painful, right? So unless it's hyperextended, like it's actually all the way into full extension, stressing that tissue into extension wouldn't reproduce any pain. In my opinion, I would be looking for trigeminal facilitation caused by a hypermobility, an irritable hypermobility, or an instability, rather than a hypomobility. 19 years after the fact, if you had a hypomobility early, within the first, say, 6 months, potentially, it could potentially cause some of these sort of things. But this is the part where I'm looking at it and I'm just like, that doesn't seem like that adds up too well to me. Like I said, there's possibilities, I guess, that these sort of things could happen, but it just seems like after that amount of time, it would be pretty calm. Or the issues would be coming from C1, C2 above it, C3, 4 below it, or maybe the 2, 3 on the opposite side. That's the way I typically look at this stuff, but it's a decent, it's put together well enough where we can kind of look at this, at least from the symptomology stuff, right?
Yeah, that's why it's just great to take a minute and discuss it in terms, because all of a sudden you manipulate this. It's the thing you have in your mind. Like I think about like the alar ligament is something I would check, is that this has been here so long, do you have one of those hypermobilities, which is being driven by this? So it's very likely that you probably would have something right above it or below it.
Oh yeah. I don't know how you wouldn't after 19 years.
Yeah. So there could
Especially
be that.
in a 65-year-old.
Yeah. So that facilitation happening around it. Now, okay, if you do manipulate this joint and freeze it up, it maybe that this joint is driving it, but it could also be, okay, what's the influence of the stress that you've taken off of one or restored it to the system? So it's just nice to keep it in your mind that when you find these subluxations like this, and maybe your pain's on the other side or around it, the interrelationship between the compensatory pattern in C1, C2, because of the subluxation at 2, 3. And once you kind of get comfortable with that, it's very liberating, because it's not one-to-one anymore. Like, oh, I did this and this didn't fix my problem. I go, no, okay, let me look at the next thing in the chain, which would be the hypermobility to compensate for this. And again, in here too, they list all the common things you can see. We chatted about it a bit in the class, and it was listed. There's that I expect to find multifidus atrophy. Poor recruitment of deep neck flexors is common. Even extensors can be inhibited. And with up ramping of sternocleidomastoid, it's almost always there. So you know that your deep neck flexors will be down, sternocleidomastoid will be up. They've also done research that showed that you probably manipulate this 2-3 and you test this muscle function immediately afterward, and the muscle function of the deep neck flexors tends to improve, and you can see down ramping of sternocleidomastoid after manipulation. It makes it optimal time for retraining in there. And that's also why it can be so hard to retrain sometimes, because if we just went with a muscle retraining model and we don't get the 2-3, they may get better in spite of us. We may only get so far and they get stuck. But once we get it cleared up, then we just want to make sure too that we work on this muscular system, which is dysfunctional. So let's do this. Let's pick a technique. So Jacob, you have a 2-3 dysfunction on the left-hand side. What are you going to do to this? What's your technique of choice?
Are we still talking about the same case where it's lacking an extension side bend?
Yep.
Same. Okay. Treatment choice here, 2-3. Probably gonna do an extension like grade 5 thrust on that involved side in supine, as long they were tolerating supine, correct?
Yeah, tolerating supine.
Yeah, that's probably what I would do then.
Okay.
What would
What's
you do?
another
Dan?
way? What's that?
What would you do?
I'm in there, but I'm going to ask you, what's the alternative technique you'd use? So you have a direct manipulation technique there. What technique could you also, what other technique could you use? Is there another one you can think of?
Yeah, the indirect technique would be, so I'd want to do a flexion technique of C3 on that same side, or I could also do an extension technique. Wait, I might be saying that backwards. Yeah, an extension technique on the other side of C3, correct? Am I saying that right?
I'm trying to picture it in my mind.
Me
Sort
too.
of. So the indirect technique would be going from the other side.
Okay.
Right. So if you're looking at, I need to close 2-3 on the left, you would need to open 2-3 on the right, but you'd want to do it in an extension position.
Okay.
Right. So you take them toward the bias and extension, and then you would open this side, and that would close the left side. That's the indirect technique. The other one that you're talking about, doing a flexion technique of C3 on the same side, is still a direct technique because you're still directly on the joint that you're trying to treat. You're just coming from below instead of coming from above, which is fine. Either one works in theory.
Okay.
Why would you think you might want to use one versus the other? So why would you come from below versus going from above?
Why would you come from below?
Yeah, when you said you could do a flexion technique on the same side of C3. So basically it's not a flexion technique, but you'd be taking C3 anterior and superior, right? So if this is C3 and this is C2, and I take C3 anterior and superior underneath C2, it's still an extension technique of that same side. You're just coming from below rather than coming from above.
I'm following. Okay.
Why would you use one versus the other?
I guess in this case, and I don't think this is the answer you're looking for, but in this case, I guess for me, it'd be easier to do that than opposed to go above and try something on C1 versus C2, just because the joint mechanics are less similar. Like C1 to C2 is different than a joint mechanic than a C2 to C3.
Yeah, very different.
So I guess just because the joint mechanics are more similar to each other, it seems to me that I would want to go like C3 on C2. But if it was like a lower, like it was C5 and C6, in terms of why I would go below versus why I would go above, I don't know if I have a great answer of what you're looking for there, but I'm sure there is an answer out there.
Well, so if we think about it, when we're doing any technique on the spine, right, and we say, okay, we have a 19-year-old subluxation on this left side. This thing has been lurking there forever.
Yeah.
This is why I was talking about just a minute ago that I would suspect that the actual joint that's creating these trigeminal symptoms, that's creating this facilitatory effect, would be one that's more likely to be hypermobile, or maybe at this point even unstable, compared to one that's going to be subluxed. Now that's where this case gets a little funny for me. But let's take it from this position, okay? So that we have the 2-3 on the left side that's jammed up, okay? It's not moving, won't go into extension.
Yeah.
What area, what biomechanically related area here is likely to get irritated by a loss of movement of the C2-3 into extension and side bending?
Like the facet joint. Are you saying something else?
Well, where would it be? Where would the facet joint irritation be?
In terms of like which side of the like which
What level? What level of
what
spine do you think?
it would be at what would be at C2 if that okay C2 is like C2-3 is hypomobile.
Yeah,
like,
it's not
that
moving.
would be the it's probably going to be the hypermobile segment that's going to get irritated then, correct?
Yes, it should be, right? So the
Yeah.
C2-3, it doesn't move. It's not coming down at all. It doesn't want to do anything. But we're
Yeah.
still getting into that extension side bending position. So where are we likely to accomplish that from?
Well, you're probably accomplishing that from C1, C2, correct? Is that
That's
that
more
joint?
rotational, right?
All right, C3, C4, or C3,
Yeah, it's
C4
going to be
then?
one of the levels
Okay.
below it, right?
Yeah.
So if I come from above, if I'm going to do a vector from above, inferior, medial, posterior, from C2 down into C3, where's my force going to go into? It's going to go down through the rest of the cervical spine, right?
It's going into a hypermobile joint.
So I might be pushing it
Embolic.
into a hypermobile joint, or an irritable hypermobility, maybe even an instability.
Yeah.
Ideally, then we wouldn't want to do that. We would want to come up from below so that we avoid putting any pressure into that irritable segment. Does that make sense?
That makes a lot of that actually makes a lot of sense. Honestly, something I haven't been thinking about, so that's really useful.
Yeah, it doesn't have a lot to do with just the instance of what we would do with this particular case, because they're not outlining that there's an irritable hypermobility below the C2-3, right? They're saying the stiff C2-3 is the painful segment, right? And so again, that kind of puts us into another interesting scenario: is, do we manipulate painful segments, or are we usually going to try and manipulate the painless hypomobility, right? Usually when we're going to do a manipulation, we're looking to manipulate something that's painless, right?
I agree.
Because when we run into pain, we're saying we're going to go ahead and manipulate through this pain. Again, that's a little bit of where this case in particular seems a little funky to me. But I mean, this is the presentation they're giving us, right? So we have to kind of deal with it. So in this case, they're probably, I mean, I haven't looked through the whole thing. They're probably going to do from above manipulation into extension. That's going to be the way they're going to correct this thing. But if you look at it from a perspective, you take away the actual case and you're saying I'm stiff at 2-3, hypermobile, painfully hypermobile at 3-4. I don't want to push down through 2-3 into 3-4. I want to come up from below and treat it in that regard, right? So we did a little bit of this sort of stuff in, what was it, module 5, I think, when we talked about locking for the lumbar spine.
Yeah.
And trying to take us away from these sort of things. It's the same thing here, right? So let's say 2-3 is stiff and it's affecting the C1, C2, like you mentioned above it. We probably wouldn't want to go through 1-2 in order to get to that, right? So we wouldn't want to come necessarily from below. We'd want to come from above in that situation. So we're moving away from the painful segment. Again, this case just has a couple of inconsistencies with the way that I see it happening in clinic. And that's okay. Whatever they see, that's what they're going to write up. But in general, we have to take some of these things into consideration when we're going in to do these techniques, especially high velocity techniques, or technically high acceleration techniques. But you guys can understand where I'm coming from with that sort of stuff. Dave, I'm sure you see this sort of thing all the time too.
Yeah, absolutely. So it's kind of that thing that's in the back of my mind, what I almost expect to see. And what's great about this is where we're going with this right now is kind of like module 7 and 8, when you start to get into thinking about more about instabilities above and below and secondary consequences and how we see it. Like with through module 6, we went in more complex techniques, but we didn't talk about a lot about, okay, bearing and locking in the Ys of moving around these instabilities. So, you can see it's not far from where we've learned at this point, but now it's kind of time to start thinking about it like in a broader text, because I do find that subluxation, but then I also want to check around it just to see, okay, making sure that instability pattern's there. Because that's where even that neuromotor retraining then becomes important, because if you have an instability around it, all you're left with there is relieving the biomechanical stress, retraining the neuromuscular system to accommodate that.
Yeah. I mean, I'm sure you guys have had this situation. I've had it happen in my clinic to patients that I've treated, or patients will mention this when they go to a chiropractor and they'll be like, oh, I went in and they did all this stuff to my neck and man, I was sore for, 3-4 days after the fact. And it was worse in those next few days than it was before I even went in. And then it started to feel a little bit better. And it's just like they probably manipulated through one of these irritable hypermobilities. And that's why it became worse for that short period of time, or, who knows, it could be longer. But that's the sort of specificity that we want to be able to have as practitioners to say, well, I know that if 2-3 is stiff and I'm sore at 3-4 behind it, I don't want to put that force through that sore segment. I want to be able to come away from that sort of thing, protect that irritability so that we're unloading it, right? That's the whole point of manipulating the 2-3 in general, is we're looking for, our diagnosis would be an irritable, hypermobility at C3-4, right? Okay, that's a good diagnosis or specific diagnosis. But our etiology is because of the stiff 2-3 above it, right? And we have to be able to correct the etiology in order to unload the tissue, the pain producer. And so it's all about specificity for us with this sort of stuff. And it's all about being able to make these things better without doing any additional harm around it. So bit off topic, but still something I thought worth talking about.
This article, I have to read this again, because here they're finding the, basically here it sounds like what they did was they manipulated 2-3, and then 1-2 they found to also be restricted. And here after what they did, immediately after high velocity manipulation, they did a whole relax technique into extension. The segment formed to facilitate cervical extensor strength, within perceived new motion. 0 to 10 repetitions, 3-second holds immediately after treatment. Pain was equal. Patient had an equal lateral flexion, bilateral. And again, restored, full rotation, painless cervical extension. John, what's the value in the contract relax technique at that point?
I think since you manipulated it, and there's a new range of motion now, so you probably want to try to get that musculature firing through the new range. And I think that's a good way to make that happen.
Mm-hmm. Yeah, and sometimes they haven't had this range in a while, and it can be, a bit pain modulatory as well. So you're going to cover somebody, I see in lumbar spine probably a little bit more so. Okay, you go ahead, you do it, you mobilize the lumbar spine, they go to get up, like, oh, my back is twingy, or it feels sore. If you go and do deep, or if you just go and do a few, 2 minutes of motor control exercises, then they're all better. It just resets the system. So if you get something that gets a little bit irritable because now you have a joint going into a range that it hasn't been going into before, I expect them to be sore the next day or so, but then better. But also doing some type of motor control exercise. In this case, they use contract relax afterward, because I know this is going to be a big change for this individual. Will have a bit of a pain modulatory effect. And so that's something whether it's whole relax or, doing some of the endurance work in the neck, I think it's a nice next step after a technique in this individual for that pain modulation. In this case, you see, immediate change in visual symptoms, as if the film was lifted, cessation of facial tingling in the left ear. And again, they basically gave her, moving into the new pattern as part of their home exercise program. With this, I would, so what I would do, I would probably have this person also working into doing the quadruped exercises, rotation and flexion and extension back into neutral, and just doing some of the neuromotor retraining afterward, just to maintain that ability to extend through that joint. And rotation will be the most functional thing that she'll probably use. Again, working into that, extension with lateral flexion patterns completely fine. I would probably add that in there, but I'd probably given just a few, like 2 other exercises to do.
Yeah, and I'd probably also have them doing the extension left side bending, so the active cervical extension thing they're talking about. I'd have them doing it as a progressive isometric, not as a just take yourself back into that position. Like, okay, that seems like that's got some potential for some issues. So mine would be more here, like start here, isometric, and then slowly working back into that range, start back from the beginning and do that maybe 10 times rather than just telling them go through active, left extension, go into actively into the left extension quadrant, 10 times twice a day. Because to me, that's not re-educating anything. That's just trying to maintain the movement path, the mobility, the articular glide of the joint, which is fine. You have to be able to do that, but I'd rather do it with the re-education process of the isometrics in those positions. That's just the way I would do it, but they got away with it apparently.
Mm-hmm. So Chan, in this one, okay, we get into visit 2, and okay, it's 80% improvement in facial tingling, tinnitus, visual impairment, improvement of active range of motion, increased tolerance of activities. She reports sharp pain, 4 out of 10 with looking over her left shoulder. There was also dizziness with transferring from sitting to supine that lasted 2 seconds. And she had 2 incidents of the headache lasting a couple hours since the initial examination. Anything in there strike you as odd? Or can you kind of in your mind explain anything away, or is there anything you want to question?
So I think the 2-second one is more of a orthostatic. The headache's lasting a couple hours. I guess I would look at that, or almost in my mind, I would think, hey, she's probably getting a little bit more increase in movement. Some of the soft tissue could still be possibly irritated with that. Did she do too much? And so if she's feeling 80% better, at least my patients, you get them feeling 80% better, and after visit 2, a lot of times they start doing more in the tissue. Either the muscles are not ready for that increase in tolerance, and so they end up flaring themselves back up a little bit. At least that's how I would explain it.
Yeah. Yeah, that's where it is. It's transient dizziness. Then again, I just ask him again, okay, what type of dizziness? What do you have? You have changes in neck joint position with that as well. So just, orthostatic is a possibility. So I just kind of want to, again, I go back through my questioning just to make sure I'm not missing anything. Though I think it's a low likelihood it's going to be vertiginous. It prompts me to kind of go back through my list just to reconfirm it. So at least in my note, if I put it anywhere, the person who comes behind me can see that, okay, I can see what Dave's thinking. He went through and checked these things real quick to make sure they don't have it.
The thing that gets me is, how did they not notice this loss of rotation the first time?
Mm-hmm.
You get 25% loss. I mean, you're missing a quarter of the amount of rotation that you should have. And this is the first time we're considering that as a potential problem.
Mm-hmm.
Seems like a bit of an might have overlooked something. I'd also be wondering what the pain producer is now.
Yeah. Where is this other one too? They mentioned. He mentioned doing a C1, C2 manipulation in the first visit as well.
Yeah, it gave consent to it.
Yeah, but I wasn't sure if they did it because it kind of read odd.
It doesn't say, or at least the parts I'm looking at didn't say.
Yeah, it didn't. Yeah, that's what it didn't describe it. So that's why I was kind of curious. I think even the upper word they talk about doing 2, 3, then 1, 2. So it's odd that you would either miss. You probably saw it on the other one, but why they didn't manipulate it or treat it, I'm not quite sure.
again, it would seem more likely that you're dealing with a 1-2 rotational issue, so that would make
Mhm.
sense. And 2-3 was the irritable segment.
Mhm.
I don't know, but again, that would mean that doing a manipulation to the 2-3 would actually make it worse, not better. So I don't know. It still seems like we're not quite sure based on how they're describing this what the actual pain producer was. You know,
Mhm.
they're describing it as 2-3, but they already treated 2-3. It's according to this thing here says that it's pretty good on the second visit as far as the extension PIVM. But now we're noticing there's a much more substantial rotational loss right above that. Like, okay, well, wouldn't you have noticed that to begin with? Especially if the patient that came in with dizziness, you'd want to go through rotation first.
Mhm.
So I
I
don't
think
know.
it's odd they didn't miss it, but you know, in that sense, take it through. Sometimes you're going to find times where you look at somebody the second time and it's like, oh, that's it. Somehow I missed it the first time.
Yeah,
It sounds like they saw it the first time and just didn't manipulate it.
that could be.
You know, they didn't go into detail on what else they did, if they did anything for that at all, or if that person just at that point after manipulating 2-3 and they saw the symptom reduction, felt like they got it, and that upper system would unwind. So you can always sometimes make that assumption that, hey, I get the primary driver, the system unwinds, and it does it, or I restore motion at 2-3, and then do I have something? You know, does that create something at 1? I want 2. I don't necessarily see it in my head right away. Why manipulating the 2-3 and improving that would create a C1 hypomobility. But again, sometimes I need to be open to what I find, even though I have an expectation of what I'm going to find going in.
Yeah, I mean that's the thing is you know objectively speaking, when you go in and you're looking at your impairments, the limitations that the patients have, you find them and it's just like, okay, well, this is where they're limited. So I guess this is what I'm going to treat. But in theory, we should be able to look at it and say, this is why it's creating this issue. Because if you're, and I had a guy that I worked with in Colorado Springs years ago that kind of treated this particular way where it was just like, oh, you know, I found this thing, so I'm going to go ahead and treat it. And it's just like, but don't you need to know what that's doing and how that relates to the issue that the patient's coming in with? Because this is Jim's thing when he's just like, you don't want to just go scattershot and do everything. Um, Number one, you're not if you have success and somebody actually improves with it, you're not going to know what you did that's actually creating that improvement, or if it's a combination of multiple things. So sometimes it's better to do the one thing and see what you get as a result of that, and then you can kind of move on to these more distal things, right? But it I don't know. It's just a funky way of putting it together, I guess, and doing it in that way.
But you can see this here. As far as a case presentation, you know, they set it up. It's pretty tidy. As far as what we're looking at and seeing there, you have and you can go to the article and see the techniques they use. They're slightly different. Use a little bit more rotation and side bending, so that's fine. In what you have now, one thing I'd suggest you like, hey, you know, segmental facilitation. I'm going to go read more on it. I don't see it out there. I think it's also important to look at, you know, again, trigeminal. We talk about facilitation, but it's sensitization may be what you're also going to find a lot of information on. I think there's a great deal of overlap between what you'd see in sensitization and facilitation. I know some of the Canadians and the model, there are differences in how you see it, but I think it lives within that model of sensitization of the trigeminal system.
I think so for sure.
So like you're looking it up and like, man, there's nothing out there I find with this. I would do your searching on PubMed and look at, you know, trigeminal sensitization, and that's where you're going to see like what we did right now overlaps into post MVA patients, post, you know, concussive patient. Maybe it's your chronic post concussive patient you're going to be seeing. You know, it could be your idiopathic neck pain that's there from, you know, postural influences or something else, or they dove into the pool when they were 22, hit their neck, and now they're 42 and they have, you know, arthrosis or a restriction there. You know, as we look at this, it isn't just the neck pain, non-neck pain patient. This is, you know, when you look at the MVA, these rules apply. And you're looking at post-concussive patient, this applies. You know, dizziness or headache patients, the same thing. This is a manual therapy model that is crossing over all of these big buckets and what you need to do. What we've given you is kind of a cohesive model versus like, okay, we're teaching concussion, so we're going to teach you 2 techniques that might work. That's not kind of how the program is set up. It's to give you this clinical reasoning model that you can be able to go from situation to situation and be able to kind of navigate your way through it. And again, we're focusing heavily on the manual therapy education portion of it, but you can see how a lot of the other treatment buckets are all a little bit more straightforward in a way, except for maybe some of the ocular stuff. The ocular stuff there's not been a great deal out there for us as of yet. But that's actually something Fred and I and Bridget from 360 Neural Health have been chatting about. All right, I think we're a little over. All right, guys, be good. Eric, we'll catch up.
Yeah, I'll reply to your email here when I get done or get a chance
No problem.
during the day.
Not a rush. Look at your calendar, sort it out, see what works for you.
Okay, sounds good.
Okay, take care.
All right, bye.